Let's start learning about asthma. I'm going to teach the basics of asthma from Marrow edition 6 and the management from Suchitra Ranjit. So let's start. Asthma is characterized by bronchoconstriction, and due to bronchoconstriction there will be wheeze due to airway narrowing. There are some prerequisites to diagnose the asthma, that it is triggered by some allergen or infection. It is reversible either spontaneously or using short-acting beta agonist. There are recurrent episodes, at least 3 or more. There should be presence of risk factors, like there should be history of asthma or allergies in the parents. There should be other allergic disorders like atopic dermatitis, sinusitis or allergic rhinitis. Asthma is more common in male gender, more common in low socioeconomic status people, and repeated exposure to tobacco smoke also increases the risk of asthma. Triggers of asthma include dust, pollen, exercise, stress, and respiratory infections. There can be different types of asthma based on the trigger. So one is atopic, which is the most common, in which the trigger is an extrinsic factor. Like in atopic asthma, the trigger is an allergen which causes an IgE mediated reaction. In non-atopic asthma, it is an intrinsic trigger like any viral infection. It causes non-IgE mediated asthma. And others like drug-induced aspirin also causes asthma and exercise. There is a cough variant asthma, presence with recurrent cough, seen in young children. Investigations to diagnose asthma are by spirometry. So there is evidence of airflow limitation. As we read that there was bronchoconstriction, so there will be low FEV1, that is the force expiratory volume in the first second will be low because of bronchoconstriction. So this value FEV1 upon FVC will be less than 0.8. In adults it's 0.7, but in pediatrics we consider it as 0.8. Bronchodilator response. So as we read that asthma is a reversible condition, so there will be a bronchodilator response and there will be increase in FEV1 by more than 12% after inhalation of the bronchodilator like salbutamol. So these were the 2 points which will help us diagnose the asthma. Others include exercise challenge, worsening of FEV1 more than 15% after exercise. What we read was in a bronchodilator response, there was increase in more than 12% FEV1, but in exercise challenge there is worsening of more than 15% after exercise. And there is a daily PEF or FEV1 monitoring, that is peak expiratory flow or force expiratory volume in the first second monitoring, in which we can see the AM/PM variation due or day-to-day variation. So variation that is more than 20% is suggestive of asthma. There is exhaled nitric oxide of more than 20 parts per billion. So why exhaled nitric oxide was increased? Because due to airway inflammation, there is increase in inducible nitric oxide synthase. This leads to increase in nitric oxide production, and this nitric oxide is then detected in breath. And the reason why there was AM/PM variation of more than 20%, because of a circadian rhythm of the airways. There's increase in vagal tone during the night or early morning, which causes the vasoconstriction, and there is increase in the inflammation and mucus. So FEV1 is lowest in the early morning, but during the daytime or evening the vagal tone decreases. This improves the FEV1 in the afternoon or evening. So in asthma, airways are hyperreactive, so they fluctuate more. Normal variation is less than 10%, but in asthma there is more than 20% variation. Now coming to management of asthma. Management is based on long-term management or management of the acute attack of asthma. So let's see about the long-term management first. For that we have to first divide asthma. It is divided on the basis of intermittent asthma and persistent asthma. Persistent is again divided into mild persistent, moderate persistent, and severe persistent. Let's start with intermittent asthma. Intermittent asthma is characterized by infrequent symptoms. The child is normal in between attacks, and we give treatment by short-acting beta agonist as and when needed. Short-acting beta agonist like salbutamol, which is most commonly used. Persistent asthma, first let's talk about mild persistent asthma. Day episode of more than 2 per month and nighttime awakening of more than 1 per month. This is called as mild persistent asthma, and we have to treat this asthma with low dose inhaled corticosteroids like budesonide, fluticasone and beclomethasone. In moderate asthma, we define it as daily attacks or need to use SABA daily. That is, the short-acting beta agonist is being used daily by the person or the child, and there is daily attacks. So we need to treat with medium dose inhaled corticosteroids. In mild, we were using low dose. In this moderate, we are using medium dose. Okay, and if we are using, or we can treat by low dose inhalational corticosteroids, but we have to add long-acting beta agonist. Long-acting beta agonist like salmeterol or formoterol. Now coming to severe persistent, it is defined by daily attacks but continuous throughout the day and night. So there is significant limitation of the physical activities, and it is treated by high dose inhalational corticosteroids plus long acting beta agonist. Okay, so initially we were using low dose, then medium dose, and then high dose. And in the last two, in the moderate persistent asthma, if we are using low dose ICS, then we add LABA. But in severe persistent, when the physical activity is being limited, we use high dose ICS plus LABA. There are alternate choices like Montelukast can be used, or sustained release theophylline, oral short course steroids, or alternate day steroids. Now coming to oral short course steroids are used only when the asthma fails to respond to every other drug. Okay, so we use steroids at the last to avoid any systemic complications. Now the asthma medication devices, we can use meter dose inhaler given along with a spacer. Small amount of drug goes in with every puff. So in less than 4 years, we have to use 3 things, which includes face mask, spacer and MDI. And between 4 to 12 years, we have to use spacer and MDI. They can use without a face mask also, but when the child is more than 12 years, by training they can use MDI effectively. Coming to Rotahaler, we use dry powder in Rotahaler, and it can be used in more than 5 years of children. Rotahaler, there is a mouthpiece, there is a rota chamber, and this is the hole for inserting the rota cap. And then when we rotate this, the drug is broken and the powder of the drug is being inhaled. Rota cap is a capsule containing the drug. Okay. Now coming to nebulizer, can be used to administer the medicines in a hospital setup. Management, we will read from Sujitra Ranji. Now let's look at the management of status asthmaticus. So in a patient who present to us with status asthmaticus, we have to maintain the oxygen saturation at more than 90 to 95%. So we can give them oxygen if the saturation falls below this range. We can nebulize the patient by 3 doses at 20-minute interval, either by salbutamol respule. One respule contains 0.63 mg. This is the easiest one to do. That use the salbutamol respule. We can give 3 doses at 20 minutes of interval. Now we can use nebulization by ipratropium. Again, combined with salbutamol, 20-minutely, 3 doses can be given. And we can use steroids, methylprednisolone, 20 mg per kg stat IV, followed by 1 mg per kg every 6 hourly. So if even after nebulization by salbutamol and ipratropium, if the status asthmaticus is not being controlled, then we can use methylprednisolone IV at the dose of 2 mg per kg. This is important to remember. Followed by 1 mg per kg every 6 hourly. Okay, and then treat shock if we suspect shock at 20 ml per kg by saline boluses. Even after doing all this, by giving oxygen, by giving nebulization by salbutamol, ipratropium, by giving IV steroids, and if shock was present, by treating that, Even if the patient is not improved, then we have to reassess the diagnosis. And even after being reassessed, we suspect that it is status asthmaticus, then we can give adrenaline at the dose of 0.1 ml per kg in 1:10,000 dilution subcutaneously every 20 minutes, like we were giving that nebulization every 20 minutes. This also we can give every 20 minutes till 3 times. Okay, 0.1 ml per kg. This is the same dose that we give in neonatal resuscitation also. Even after giving adrenaline, the patient has not improved, then we can give injection magnesium sulfate in the dose of 50 mg per kg in 10 ml saline over 30 minutes. So first we gave nebulization. If the patient has not improved, then we gave adrenaline. Then we gave injection magnesium sulfate. And magnesium sulfate dose is important to remember, that is 50 mg per kg in 10 ml saline over 30 minutes. Even after giving magnesium sulfate, the patient has not improved, we can give terbutaline infusion. Terbutaline infusion, the dose you have to remember is 0.05 to 0.1 microgram per kg per minute infusion, and reduce the dose if the heart rate increases by more than 20 per minute over the baseline, or ST changes can be seen. Then we have to stop the terbutaline infusion. If even after this terbutaline infusion the patient has not improved, we can use aminophylline infusion. And if we are giving aminophylline infusion, we have to reduce the terbutaline infusion by 50%. Then we may need to consider mechanical ventilation and anesthetic gases. And even if after the nebulization our patient has improved, then we have to do hourly nebulization with salbutamol and up to 3 to 4 doses. May increase the nebulization interval to 2 to 4 hourly, and we have to continue the steroids till the patient is recovered completely.